to discuss about the metabolic disorders leading to heart attacks in this country. Today's session, we have a very distinguished panel to moderate and take the questions and discuss the issues. At the very beginning, this session is going to be chaired by Dr. Vijay, and we are really privileged and honored to have such a distinguished person on the board today. He is the chairman of the Scientific Committee of the Cardiological Society of India 2022, and he will be taking over as the president of the CSI, which is the largest body of the professional body of cardiologists in India. And he will be the president from 2023. Dr. Bang is a very distinguished interventional cardiologist. And, he has initiated, not only nationally, he has even initiated the interventional programs as far as in Kenya, for which he has received commendation. And he is a very distinguished teacher, being the professor and a honorary professor of Grant Medical College and Sir J.J. College in Mumbai. And currently he is the honorary consultant in Lilavati Hospital and Research Center in Mumbai. He has a huge number of angioplasties to his credit, and he's a distinguished teacher taking part of the DNB, DM programs, and so many honors and awards to his credit. And today we have him to chair this session, and it's a real honor, sir. We have Dr. Manish Bansal, Senior Director of Cardiology, Preventive and Clinical Cardiology at the Medanta Heart Center, New Delhi. He is a very distinguished academician and is on the editorial board of several journals, being the editor chief of Journal of Echocardiography and also the JACC Imaging. And he has over 250 publications to his credit. And needless to say, he's a dear friend and has been a very constant motivator for me to do research in many areas. When I get depressed, I talk to him. Dr. Roshni Sandhani is a new acquaintance. Hopefully, we are going to collaborate in future. I'm very impressed with her profile, and I thank Dr. Vijay Bang for introducing her to this forum, and it's totally to his credit. Otherwise, I would have never known her. She is an endocrinologist, certified endocrinologist, both from the United States, and she is practicing there. And she returned back to India, initially worked in Hinduja hospitals, and finally she has Asana, her own center. And to reach out, not just the Indians, but across the world, she reaches out anywhere in the world with her. She's very passionate, from what I could understand, a brief interaction I had with her, very passionate about many of the areas which we generally neglect as clinicians in cardiology. And really, it's fascinating to have somebody like her in a hospital to motivate the patients in spirituality, emotional eating. These are the areas which we are totally ignorant of. And welcome, Dr. Roshni. It will be a pleasure to hear you today. Dr. Srinivas Raju, my friend of many decades, and he is a senior interventional cardiology and a director of cardiology at the KIMS Hospitals, Nellore. He has a huge number of over 10,000 angioplasties to his credit and several adducts, and he's a very popular and a very loved cardiologist in Nellore. Whenever I go there, I can see that ambience of affection of his patients that they have for him. Welcome, Dr. Srinivas Raju. And importantly, he has been an important contributor to this study which I'm presenting today, the Merifac study. And he was one of the persons who recruited and helped in this study to go on. Now, I hand over this session to Dr. Vijay Bang to conduct the session today and take over, sir. Please, sir.
Thank you very much, Dr. Hygriv. It has been an honor and pleasure to join all of you on the same platform. And this is a study which is very important. Even I am very much interested in preventive cardiology, despite being very aggressive angioplasty or interventional cardiologist. I have been very fortunate, extremely fortunate, that I got a chance to become honorary professor, head of cardiology at Grant Medical College, and then of course at Lilavati Hospital. And then now President-elect of Cardiological Society of India this year and Chairman Scientific Committee. And next year is our 75th year. India celebrated 75th year in 2022 of independence. And next year is our CSI's existence 75th year. That's a platinum jubilee year, and I am humbled to be officiating as president in that landmark time. So coming to this topic, which is of great interest, we all know that CAD is #1 cause of death in the world. And the main problem of CAD comes from few risk factors. In day-to-day practice, we see them. Once you have put on weight, you develop diabetes, you develop hypertension, and you come into cardiometabolic zone. And then if the renal comes in, then you have several other issues coming up, and that gives a chance for CVD to prop in. Now, how do we go about so how do we lead a healthy life? That's a very important aspect, that we need to lead healthy life. So it doesn't even apply to our patient, definitely applies them a lot, but it mainly applies to all of us also, that we also need to lead healthy life so that we can treat maximum number of patients very effectively and very well. So what is that which will bring this? This is a will which we can call a life essential 8 will. This will is basically proposed by Dr. Donald Lloyd Jones, who's the AHA president and my very good friend. He'll be joining us in the CSI in the same forum, and we will have a session on preventive cardiology, which will be called as CSI Global Leadership Session, which will be very interesting. So if you want to lead a healthy life, then few things you must do. One is do a good number of physical activity. Be physically active. Don't be sedentary. Keep moving. Apart from doing a cardio exercise, you should keep moving exercise and also muscle strengthening exercises. And eat a balanced diet. Balanced diet is what? Fresh chopped vegetable, fresh chopped fruits in maximum quantity. And pulses, boiled pulses. This is the best food that we can have as a vegetarian. And of course, if you're a non-vegetarian, you have option of eating a fish also. So if you manage your weight by regular exercise and proper healthy diet, you will not get diabetes. You will not put on weight. Your lipids will be normal. Your blood pressure will be normal. And of course, you won't smoke. And if you have a good sleep and healthy mind, then you are a healthy individual. So these are simple 8 components of healthy life. For women, we need to add a maternal aspect of it. If they develop during pregnancy, if they develop gestational diabetes and hypertension, they do have increased chance of CVD in future life. So coming to this very important NHBLA data from America. What is the data says? That if you look at the blue color, it is ideal. The red is intermediate and poor is green. So if you look at the few parameter, smoking, you can see a lot of blue. How this happened? It happened because of the effort of medical community. They have successfully convinced people not to smoke. So number of smokers have come down in the world, definitely. So one risk factor, definitely we have been able to manage the control. What we could not have, what so far we have not controlled is something very important. That is the lack of physical activity and poor diet. You can see the diet, all green, it's very poor diet. Whether you are below the age of 20, about between age of 20, 49, or above 50. The diet is very poor, and physical activity is also not adequate. 50% of us don't do any physical activity. So this is the main message, which increases BMI, increases cholesterol, blood pressure, and diabetes. So this is the circle that we are going to talk today. And if you go to see this very important diagram, which is very vital to see, this diagram is very important for all of us, a very important study. Where is the diet? We have a diet color as violet. Where is it? It is in the bottom on the x-axis. So our diet is extremely poor. We need to convey this message to all the community, world community, that they need to eat healthy for maintaining healthy heart. Otherwise, they will die of heart disease. Some die of in younger age. We see a lot of young patients dying due to heart disease, cardiac arrest. 65% of our cardiac arrest is due to MI, acute myocardial infarction. Second, physical inactivity, physical activity, that is PA, which is green. So what is happening? It's here. Physical activity very poor, and then there is a break because the questionnaire has changed to define physical activity by NHBLI. Now what is happening? The physical inactivity is so profound that two together, the poor diet and physical inactivity, increases the BMI. Where is the BMI? This is the BMI. So all this is a vicious circle to lead to cardiometabolic syndrome. So there is a shift in the epidemiologic shift in the risk factor. Smoking has come down. But other end, obesity and glucose intolerance has gone up. And obesity, diabetes, hypertension, hyperlipidemia has gone up significantly. So if you look at the mortality chart, this is adjusted to the population. Mortality chart, the up to 2019, the mortality was coming down with our efforts to treat cardiovascular disease, be it intervention, catheter intervention, or surgical intervention, or medical treatment. All three can definitely help patient prolong the life. India had, when India got independence, the life expectancy in India was 32 years. Current life expectancy in India this year is 72 years. So 40 years are added due to efforts of the doctors and research. So no doubt we are effective, provided we work together. This is something which is not adjusted to population. So what we see here is increasing, and this trend is from 2015, well before, but this is not adjusted to the population. So maybe that some areas people might be dying more, so it may not reflect true picture in the community. So this is all about that I wanted to say in terms of what we have today is cardiometabolic syndrome and ACS. So how to cut down the ACS, how to cut down the all the risk factor which lead to ACS and CVD. That is what our topic is today. And to begin on one study called as metabolic risk factor in first and acute coronary syndrome. So Merifax, study done by Hygriv Rao, Dr. Hygriv Rao, and I invite him to present his topic.
Thank you. Thank you very much, sir. That was a great introduction to the problem of the CVD and how it is going to be in the next decade also. Thank you very much. And I'm just going to talk about my study. Now, acute coronary syndromes in India, they are different from the rest of the world, and they are very concerning too. First thing is, there is a very high prevalence of acute coronary syndromes in India. And despite the fact that so many positive things are happening around the world globally, the prevalence in India is increasing by the year. And more concerning is it occurs in younger population when compared to the rest of the world. This is a matter of concern because it involves the economically productive age group. It causes MIs, heart failures also younger, and sudden deaths are also younger. There are other problems which we are not going to talk today, but one need to know about ACS in India. That is, the time to presentation is later, the recognition is later, the availability of thrombolysis and revascularization is less. And so the patients who have myocardial infarction have more often STEMI or ST elevation myocardial infarction. The scars which they form are large and predominantly because of late reperfusion. And because of this, the heart failures and sudden deaths are more common. In fact, we published a study in 2012 showing that SCD is the first presentation due to unevaluated risk factors in India. And unfortunately, it continues to be a problem even till today, 10 years after what we recognized. Now, look at some of these studies. We cannot, I did not pick up all the studies, but important studies of acute coronary syndrome in India. There are some things which are very, very common. Now, the largest study, initial study, earlier studies was the CREATE study, which gave us insight into what ACS in India is. The last study, 20,000 population. Now, the large global study is InterHeart study, again, thousands of patients, but the representation from India was not very high. We did a single center study of 929 patients in 2012, which we published, and very prestigious Kerala Heart study of 25,000 patients. Now, what I want to tell you is there's something very common in all these studies. Please see the age. They're all between 53 and 60 years of age. So this is what I was trying to emphasize, that the heart attacks in India occur in very young group in the productive age groups. And see the males, 70 to 80% are males. So 50 years males is 50 to 55 is a very important risk factor of MI in India, involving the productive age group and causing a great economic distress to the society at large. And also look at it less than 50 years. CREATE study, 30% of the patients were less than 50 years. Very saddening. And so is in our study, and the Kerala study also showed 22% less. InterHeart did not look at 50, but they looked at less than 40 as a 9%. Again, showing that in India, somebody having 35 years or 40 years or having an acute myocardial infarction is not uncommon. And importantly, STEMI is a very important predictor. The large infarct, 61% of the CREATE study was STEMIs, and so was, we studied only STEMI in our data, so we have 100% STEMIs, and it was not specified in InterHeart, but 37% of Kerala ACS studies was STEMI, 31 were NSTEMI, and the remaining were unstable angina. So as we can see, large infarcts, younger age group is important. Now, second thing is look at the risk factors. This is, I'm coming to the main crux of the topic we're going to discuss today. The CREATE study, the largest study, it looked at only smoking, diabetes, and hypertension as the risk factors. And same with Kerala Heart study, smoking, diabetes, hypertension, and past myocardial infarction. Even we looked at only these risk factors in the family history of coronary artery disease. On the contrary, InterHeart was very important because it looked at 9 factors. Smoking, diabetes, hypertension, everyone were looking for. They also looked at very important metabolic factors like waist-hip ratio, ApoB by ApoN ratio, stress, alcohol, exercise, and food intake. They found that exercise and food intake were positively inclined. They caused less heart attacks. The rest of the things, they caused more heart attacks. So this was the first study, a large global study, involved South Asian countries, showing that factors apart from smoking, diabetes, and hypertension are important for heart attacks. This is very, very important. Now, if you look at the traditional conventional risk factors for ACS, in all the studies that I've talked about, and that we practice as clinical cardiologists, hypertension, smoking, diabetes, and elevated LDL. This is what we generally look forward in all the patients, or even with patients people who come for general health checkups. What we don't really look for is the other things. And these were special risk factors in Indians, which are studied in different studies. Interheart was one, and there are so many other studies too. What they did was they looked at psychosocial index, ApoB by APO1 ratio, LP little a. There's a lot of data when Inas and Inas spoke all over the world on LP little a for Indians born in India as well as elsewhere. Homocysteine, there was a lot of literature on homocysteine in the early 2000s. Problem is, these are economically and logistically not feasible, because for a routine point, when we talk about risk factors, we will talk about somebody who living in a small village in the remote corner of India and in the urban area, as well as even a underprivileged person, even living in cities. They're not economically, logistically feasible, and they didn't take off despite being 20 years of. Now, we look, as a clinical cardiologist, we talk to a lot of cardiologists across the country informally, and then realize that there are some simple indices like body mass index, waist hip ratio, HbA1c, HDL, and triglycerides. Why did we choose this? We realized that obesity was a very important problem. Every person, when I looked at my clinic, was either overweight or obese. Just look around the hospital, people waiting, patients, relatives were waiting. They also were found to be obese. And so I thought there is a lot of importance in obesity. And similarly, we talk about diabetes, but very little we talk about HbA1c. Although we know HbA1c is important, in general practice, people ask, are you diabetic or not? And the matter ends there. Very little is really done in all the centers across the country aggressively. Few centers certainly do, few cardiologists certainly do. But if you see across the country, HbA1c is relegated to the background. One of the reasons being is an expensive investigation to do it every time for all the people. And similarly, the indices of exercise like HDL, again, are not so much seriously taken. Now, all these factors, they are less often assessed. And many hospitals don't even check the waist hip ratio or body mass index seriously. And even if they check, these are rarely intervened. And even if intervened, they are not target oriented. You don't ask each time a patient comes to the hospital, like, did you reduce your BMI from 30 to 29 or so? So, and the perception is that these are important, no doubt, but they're less important than conventional risk factors. This is the point that I am trying to make, and this is the most important crux of the paper. It is less important than conventional risk factors, but they're important. We have to give them some kind of importance. You please don't smoke, take care of statins, but as a matter of fact, saying, you please also lose weight. And also, these can't be easily assessed in many places in the country. There's another problem. So this study, metabolic risk factors in first acute coronary syndrome, it was over a study which was conceived for 6 months, conducted for 2 years, analyzed for 1 year, and finally published after 1 year. So this study was taken across 15 centers in the country. All patients had first instance of ACS or STEMI or NSTEMI. This is very important. 24 hours of admission, and we had controls for healthy populations who were coming for health checkup, and these are 1,212 patients and 2,150. The reason why we did not take one-to-one was because of the COVID. While the study was going on, the COVID peaked, and the healthy populations were very difficult to get and screen. So statistically, we found out 1-to-2 comparison between the controls and the study cases. We excluded anyone who had a prior acute coronary syndrome, anyone who had a bypass surgery or angioplasty before, anyone who had an angiogram documenting coronary. In short, none of the patients had ever taken antiplatelets before, and so those were excluded. So these were primarily the first heart attack patients across the 15 centers in the country. Now we had 15 participating centers across the country, 4 in Telangana state, 5 in Andhra Pradesh state, 2 in Kerala, 1 in Karnataka, 1 in Tamil Nadu, 1 in Madhya Pradesh, and 1 in New Delhi. So these 15 participating centers enrolled. We made sure that none of them had too many or too less. So they were certain side of evenly distributed, so there would not be any geographical bias. So we defined the conventional risk factor according to the standard guidelines which were taken from the textbooks. The hypertension was more than 130 or 85, or if the patient had a previous diagnosis of hypertension, or he was taking treatment for hypertension prior to admission. Diabetes was according to 2018 guidelines, fasting sugar of 126 and HbA1c more than 6.5. LDLC was recommendation of the National Lipid Association of more than 100 was taken. Smokers, any kind of tobacco, smoking or consume tobacco in any form, these were taken as current smokers. And those who quit also were defined as ex-smokers, and whether they were ex or current, we took them all as smokers for this purpose of the study. So these are the important values which we are going to compare. A BMI, we are aware that India, there is a data of BMI being 23, but we took an international guideline of 25. The waist hip ratios cut off for 0.9 for men and 0.85. This was according to the Interheart study. HDLC less than 40 and less than 50 in women were considered low. And hypertriglyceridemia was taken as 150 and HbA1c was 7. Please note that we took two things. The previous study, we took patients with the conventional risk factors as patients who had diabetes, present or not present. And we were more interested, not just the presence of diabetes, but uncontrolled diabetes, HbA1c of 7 or more, indicating uncontrolled diabetes. This was a major specific metabolic risk factor that we considered. The study flow were all adult patients with STEMI or NSTEMI. These were recruited in study. After statistically, when we checked for propensity matching by sex and age, we realized that 193 were the final number. And normal adults were 1210. And patients, as I said, we took conventional risk factors 4 and compared them with the specific metabolic risk factors, which are less commonly used, these 5. This is the purpose of the study, is to see whether these are as strong in causing acute coronary syndrome as the conventional strong risk factors that we globally, everybody used to control. Now, this slide is important because it will give us an idea about what is the kind of ACS in 2020 in India. You see the 2000 patients, 76.5% were males. The mean age, again, as I showed in the first slide, always younger, still 56 years was the mean age. And we had an equal distribution of rural and urban. And predominantly the patients, they were not selected, but patients were STEMI, 83% were STEMI. This is a very, very important point, which I found in all studies that I have done, which the Western reviewers actually, they find it very hard to even to accept that in India, STEMI is such large, like 83%. Rest of the world, STEMI is not that large. That is the very important point that we found. And consistently, that I have seen in all the studies that are done in this country. If you look at the socioeconomic status and the education cohort, we had the different strata. This socioeconomic status is as per the Kupuswamy socioeconomic classification by using various parameters like the family income, educational status and other things. They have a scale. And as you can see, we had upper middle and lower middle constituting the majority of our patients, and there was no difference between cases and controls. The extremes like very upper and lower were, they're minority in the population. The education background, again, we can see that no education and higher school or lower education constituted about 50% of the patients. The remaining were distributed at college or postgraduate education. And these were also similar in controls. So we had, what I was trying to say is we had equal rural and urban. We had patients coming from different socioeconomic status and educational backgrounds. Now, clinical, again, this is again just to understand the ACS of our country. The time to presentation, even this, I've been seeing the studies since the last 20 years. Somehow, the time to presentation in India is always longer, 8.3 hours. 33% had thrombolysis, 38% had primary PCI. PCI, because these are all tertiary care centers, the primary PCI was a little larger. Nevertheless, importantly, even you can see that 30% have no reperfusion, even when I took tertiary care centers. So because they arrived too late, you can see that the angiogram was done in majority of the patients because of the tertiary care centers, and they are distributed single vessel disease, double vessel infusion. Now, the important thing is the survival to discharge. In my previous study, I always used to think India, the survival to discharge, 90%, 10% mortality. But somehow here you can see that there's an improvement in the treatment modality, 94% survival to discharge. Now, the age distribution of the ACS patients, again, you can see that the 50 to 70 years is a peak age in which all the patients were distributed. Now, women were definitely less, males were more, but if you see women also, even amongst them, if you see 50 to 70 is the age group that women are. No doubt women, as in the elderly, more than 70, women were more than men. But what is to be remembered is that even in the peak age 50 to 70, the men and the women both are having a large number of incidents of MI. Now, coming to the crux of the study, we looked at the risk factor prevalence, conventional, hypertension, smoking, diabetes, and LDL, high LDL. And if you look at it, you can see that hypertension 39% versus 16%, smoking 28 versus 9, all are statistically significant. And these represent the odds ratios. High odds ratios, hypertension, smoking, diabetes. Here we just took diabetes present or not present, nothing else. And 5.3. And high cholesterol in 70% versus 57%. I'll come back to this slide a minute later to speak about the controls. Here I just want to show that all the risk factors are higher in cases when compared to control statistically with a very high p-value, 0.001. This is not unexpected. Everybody knows this across the world. Now, this is what is important. Now, high BMI, because BMI did not show statistically different from cases and controls, but it was very high, 54% and 55%. But the other index of obesity, waist hip ratio, was significantly higher in the cases. And the low HDL, 56 versus 42, again, statistically very significant. And this is what differentiated from diabetes. Uncontrolled diabetes or high HbA1c, 37 versus 12, again, more importantly, more prevalent in the cases than controls. Triglycerides level, so again, not so high statistical p-value, but definitely were higher in the cases than controls. Now, what I want to show, one more thing, that when I was looking at these slides, one thing that strikes me and will strike you also is look at the controls. If you look at the controls population, hypertension, smoking, these are something like 14 to 16%. So in other words, these seems to be little better there in the normal population, better controlled normal population than the patients with ACS. But you look at the metabolic factors, there's a high incidence of dyslipidemia. 57% of the controls of normal people have LDL-C. And look at these metabolic factors. All of them are so high. The waist hip index, even control 63%, and high triglycerides 44%. What was strikingly there is even people who are totally normal, these are so high, it doesn't take much time for them to become cases if unintervened. That's what I felt. This is not the purpose of the study, but that's what I could realize. So, but what is important from these two slides is that if you look at the cases and controls, hypertension, smoking, diabetes, and high LDL, all are statistically very high in ACS population. High waist hip ratio, low HDL, high HbA1c, and high triglycerides are more in ACS population. BMI was not different. Then we looked at the mean values. Again, the mean values, just to show that the cases was 120 LDL, 99 in controls, the BMI 25 and 25, his waist hip ratio 0.91 and 0.86, HbA1c more than 7 and 6, HDL-C 38 and 41, triglycerides 170. This was the mean values. What was important was this slide is the most important slide of the paper. Here we compared all the risk factors, hypertension, LDL, smoking, high waist ratio, with the metabolic as well as the conventional risk factors. And we looked at the odds ratios. Now, what was striking was, everybody knows hypertension has 3 times more risk in ACS, LDL has 2 times more, smoking 6 times. But did we ever think that just high waist hip ratio was as much important as high LDL? We always think that LDL is very important, we give statins. Did we ever think that high waist hip ratio was as much important? And similarly, more than diabetes, uncontrolled diabetes, 4.6 times. And only thing that didn't, in the multivariate analysis, what didn't show was the triglycerides, just 1.2. It is, again, it moved out. The BMI moved out of univariate analysis, the triglycerides moved out of the multivariate analysis. So what remained was, apart from hypertension, high HDL and smoking, what remained was the high waist hip ratio, high HbA1c, and the low HDL or the protective cholesterol. These were very important. And the multivariate analysis shows that their odds ratios were comparable with the conventional risk factors. And we just combined diabetes, hypertension, diabetes, HDL, 2 conventional risk factors, and we compared 2 metabolic risk factors like the HbA1c with different combinations. Now, I don't want you to look at each graph very carefully. Just want to show the orange curve, the specificity. You can see whether it's conventional or specificity. the specificity seems to be very high. Negative predictive value also seems to be uniform. Whether you take hypertension or you take triglycerides or HDL, you see the negative predictive value almost seems to be 50 to 60, same, showing that if you do not have any of this, if you don't have hypertension, very good. If you don't smoke, very good. But if you are not obese and if you have a good HDL, also it is as good as not smoking and not having hypertension. That is what this slide clearly shows. Similarly, when we compared the 3 risk factors, again, more than 2, we compared 3 risk factors. And again, we can see that the orange curve, the specificity is very high, 90%. And the yellow, the negative predictive value is almost similar. So the more you do not have the metabolic risk factors, it is as good as not having the conventional risk factors. And not having any of these is the ideal and the most important. So in conclusions and clinical implications, first thing, ACS has very high prevalence in India, affecting the younger population. This is a point I reiterate again and again, and it's very concerning. And unless we do something about it, 10 years, I was presenting the same slide in 2010, the same slide, same sentence. I'm presenting in 2020, and if we do not do anything about it, in 2030, if I'm still around, I'll be presenting the same sentence. There is a large prevalence of metabolic risk factors in our population. There are 97% of the patients had metabolic risk factors in our population, and 90% had conventional risk factors. That was the comparison. HbA1c, HDL, waist heat ratio, they are important, but they are as important as hypertension, smoking, and LDL. This is a point that this paper I want to make, although these look very obvious, but that they are as important is the point that this paper would like to make. Now, what is the clinical implication? Now, these factors which I'm talking about, the important metabolic factors I'm talking about, they are in fact the surrogate markers of obesity, sedentary lifestyle, poor diet, and improper diabetes control. This is exactly what these markers are. Of course, the study did not look at these endpoints, but they are certainly the surrogate markers of these clinical points. Preventive measures of coronary artery disease are optimal only if all these factors are addressed, not just hypertension, diabetes, and smoking. And these specific metabolic risk factors are high in control population too. As I was making a point I was making in the slide. They need to be targeted aggressively at younger ages. That's very important. Because if we do not do that, all these controls will eventually become patients, ACS patients. Because between controls and ACS patients, it is just one day. A person who is controlled today, if he develops a heart attack today night, he becomes a patient. So this is a point I would like to make. Thank you very much for a patient hearing. Sir, you're muted. Sir, muted, sir.
Yeah, of course. Sorry. It was an excellent presentation and study was very focused. What I like about study is very focused on metabolic factors. And because of that, what details you got in the study, when you express various graphical presentation, it looked like absolutely true. That metabolic risk factor is the biggest risk factor. And to explain all these in greater detail, Roshni is coming, of course, and she will present the reducing global burden of BMI, cardiometabolic syndrome by healthy diet and exercise, which we all can. Roshni, you are present.
Okay, thank you so much. First of all, everybody, Dr. Bang particularly for inviting me here. The opportunity to speak to a cardiology audience about this is very, special because we all, endocrinology, cardiology, are dealing with the same syndrome. We are dealing with metabolic syndrome, cardiometabolic health. When we say the word metabolic, the master metabolic hormone happens to be insulin. And if I have, in one line, if I have to summarize what probably ties together the metabolic points which Dr. Rao just showed in his study, it's all about insulin resistance. And Dr. Bang and I spoke before this presentation that how shall we go about conveying to all of you what are some simple proofs that lifestyle change can actually work And if some of this stays in your mind when you see your patients going forward, small points to get more confident to work with your clients or patients on lifestyle change, knowing that there is such strong evidence and such powerful small things that we can actually do to help our patients save their own lives. So with that, I'll start. Okay. So very quickly, I know we are limited on time, and I will try to stick to some time schedule here. I suppose everybody knows here that I am a endocrinologist. After completing my MBBS in Mumbai, I completed my higher studies in Chicago. And after finishing private practice there for a couple of years, we came back. And I've been in Mumbai since 2011. Aside from my professional qualifications, I'm a very curious learner. And I think what has made me the lifestyle endocrinologist that I am today is because of deep curiosity in these subjects. I became a diabetes educator. I got trained in mindful eating, which is emotional eating, overeating, binge eating, the relationship between me and my food. I became a personal trainer because doctors don't know anything about exercise, nor do we know anything about nutrition. Very honestly, it's not part of our MBBS curriculum. And I learned about emotional freedom technique, just again a self-help tool to help people manage stress. I got trained in motivational interviewing, which is a behavior counseling coaching style that helps the patient decide for themselves what they want to do, rather than the traditional model, which is the doctor tells the patient what to do. It's more of the doctor takes the role of a guide and gives maybe a menu of educated options so that the patient gets to be in charge of their own life and their own choices. And science has shown that this works actually for all kinds of addictions, and it is now coming into mainstream medicine to help people make healthy behavior change. And spirituality is a big backbone of my approach to life and to healthcare. So, how strong is the evidence? We doctors love to practice evidence-based medicine. So, is there any evidence that making lifestyle change for cardiac health will actually help? Let's look at it. So, I tried to go into the cardiology literature today instead of where I normally stay on the endocrine side. Of course, we all have to cross-read with internal medicine mindset. But still, I wanted to go into cardiology literature. And the 2019 AHA guidelines talking about primary prevention of cardiovascular disease. This is their chart on exercise, and they have a level 1 class of recommendation for that we should talk about exercise. But even talking about exercise is not backed up by evidence. Okay. And there is a level 1 recommendation about a particular diet, but it doesn't have the highest level of evidence. So there is actually a paucity. This is in the 2019 guideline itself, where they say clearly there is a paucity of large-scale prospective randomized trials with RCT design focusing on hard cardiac outcomes. Okay, so when we make recommendations, we need to know the difference between am I making recommendations or am I stating evidence? It's very important to know the difference. They're not the same. So why should I do it then? I mean, why should I make lifestyle change advice and spend time in my busy OPD talking about things which may not even be saving my life of my patient? So let's look at some studies on that. This is Journal of American College of Cardiology, influence of lifestyle change on incident cardiovascular disease and death. They looked at the hardest outcomes possible, CVD incidence means new events, or CVD mortality. And you can see this downward slope in the hazard ratios. As you put in more and more low risk lifestyle factors, the more number of healthy lifestyle factors you have, the CVD incidence and CVD mortality starts to drop. So this was a large study funded by the government of US, and it was done at Harvard, 11,000 patients with type 2 diabetes. And we say type 2 diabetes patients have the highest risk, correct? We say it's almost a cardiac disease equivalent, right? So this many people who were CVD disease free at the beginning showed that there was substantially lower risk of CVD incidence and mortality after making lifestyle change. And as Dr. Rao showed you the combinations of metabolic imbalances, this paper looks at combinations of 3 or more lifestyle changes, literally bringing the CVD mortality down. So this was actually very reassuring that it is actually worth it to help our patients make the lifestyle change. It's life-saving. So now let's get specific. And of course, talking about nutrition to save your life could be a whole day conference, right? So let's be brief. Healthy oils and the Mediterranean diet. This was a beautiful study in the New England Journal, again, 2018 June. It's called the PREDIMED trial, and it was looking at primary prevention of cardiac disease. So that means they've never had any cardiac issues ever before. And the Mediterranean diet was to supplement them with olive oil and nuts. And the looking at, you can see here the graphs literally drop when you give them the olive oil and the nuts. Compared to control, you have a lower incidence of cardiac events and lower mortality of cardiac events. So there were lower hazard ratios compared to the low fat group. Obviously, when you're giving more nuts and oil, those end up being much more fat intake. And that's actually something which has been proposed a lot by a cardiologist in the UK, Dr. Aseem Malhotra. He's written a book about it. This is his book about the Mediterranean diet being the heart healthy diet. And the food pattern in the Mediterranean diet is olive oil as the primary fat. In that particular study, they were adding 4 tablespoons of olive oil per day, and they were having about 30 grams of nuts, like a handful of nuts. They had a combination of walnuts and hazelnuts and some other nuts, but a mix which was given to them to eat every day. And they were allowed to eat without any calorie restriction. Naturally, when you take more fat, you don't feel so hungry. So they were naturally managing their food intake. There was no diet or calorie counting. Fish, for fatty fish was allowed, and eggs or dairy was either daily or a couple times a week. Lots of vegetables and unprocessed carbohydrates. So I'll come to what is unprocessed carbohydrates, and some low carb fruits like berries. What about saturated fat? So this is a major controversy which started back in the 1960s in the United States, and the whole world has been following something that started back then in the 60s and 70s. And this whole idea of asking the public to switch polyunsaturated fatty acids for saturated fat. So we were told that the world was told saturated fat causes heart disease and you need to switch to PUFA oils and vegetable oils or refined oils. And actually 50 years later, we are all sort of, anybody who's in the metabolic world is regretting that we followed that advice. And the reason we think so is that it has been shown to derange the omega-3 to omega-6 ratio. It causes the inflammation, it drives the insulin resistance. And whereas when you start to repair from that, you would be moving to the high-fat Mediterranean diet and the exercise to reduce the inflammation that's happening, which is the trigger for the plaque rupture. So what about PUFAs? Because we still in India are still very much being bombarded with the advertising for, so to say, heart-friendly oils. So what is there in the evidence? This is British Medical Journal 2013. Using dietary linoleic acid. Linoleic acid is in most of your refined seed oils. It is rich in omega-6. It is the most common omega-6. And this was a study done for secondary prevention of coronary disease. That let's take this high-risk group. And now this was done, this study was a group of people in the 60s and 70s, exactly when this whole change of thinking was coming, that maybe we should reduce saturated fat. So this study was done where they replaced, the intervention was to replace dietary fat with omega-6 linoleic acid. You'll recognize this, safflower oil and the PUFA safflower oils were given as the primary fat. And this data had to be actually, so there was missing data, which even though the study was done in 1973, this has now come in the public eye in 2013. And it literally said that substitution, where you took away saturated and moved into linoleic, increased the rates of death from all causes, coronary heart disease and cardiovascular disease. So we need to question the worldwide dietary advice to make this substitution. Another study that got buried during that time was the Minnesota coronary experiment. Although it was completed in 1973, it came in the British Medical Journal in 2016. And again, this is what we call the diet heart hypothesis, that a diet rich in saturated fat causes heart disease. That was the hypothesis made in the 60s and 70s. And actually, this paradigm has never been causally demonstrated in RCTs in the last 50 years. Okay, but the person who proposed this idea was a very persuasive proponent of it, Ansel Keys. There's a lot of literature now coming up about the whole controversy back then, but this change did not translate to survival. So this is a paper, science paper from one of the Indian journals of biochemistry, looking at the oils, because we in India, we love our oils, we love our tadka or our tempering of the spices and making the seeds pop and frying things. So this was looking at the oils which have been recommended, the PUFA or the vegetable seed oils, and looking at what happens when you heat them up, because we know now the ratio of omega-3 to omega-6 is important. And what they found was coconut oil was stable, ghee and butter were stable. And this was their chart showing you. I added over here myself about olive oil. Since we keep on talking about olive oil, it's good to put them on one chart. Is the profile of saturated fat versus MUFA versus PUFA. You can see olive oil seems to be doing well because it's high in MUFA, and coconut oil and ghee are doing well because they seem to be high in the saturated fat. The logic now is, if you have polyunsaturated, you have all these open spaces which can be reactive, which can bind with other molecules and create these chemical reactions in the body. So this was the experiment done in the scientific journals in India. So then what about keto? This was a publication done by a cardiologist, Dr. Eric Westman. He's a proponent of low carb and keto diets, and he compared it to low fat diets, and they looked at with NMR, nuclear magnetic resonance, looking at the LDL and the lipoprotein particle sizes to look for atherogenic particles. So they made two groups. One group got the ketogenic diet, where they were given fish, borage, which is a Mediterranean plant. It's a flower, which seems to have some health benefits in the Mediterranean region. Flaxseed oil, obviously for its omega-3 benefits. And the other group got low fat, low calorie, which is what everybody was always telling the patient to take. The population was the high risk one. BMI was 34. The study went on for 6 months. And guess what? The ketogenic group, better improvements in VLDL, LDL, particle size, and HDL particle size. So ketogenic was superior. And the idea here is that it moved the lipid profile from small, dense LDL to large, buoyant LDL. So again, making the LDL profile less atherogenic. What about sugar? Everybody here needs to know that sugar is not healthy. There is no kind of sugar which is healthy. We eat it for pleasure and pleasure alone. And it's up to us to find how much sugar is what we can manage as a balance between pleasure and health. I say this all the time in my practice every day. And if you want to bring your cardiac risk down, bring your sugar intake down. That doesn't mean stopping the sugar in your chai. It's not only that, okay? But I'll come to what are other sources of sugar, but why to do this from a cardiology point of view? This is the poor man's NMR study. It's very expensive, as Dr. Rao mentioned, to do ApoB testing and to look at the NMR profiles of lipids for looking at this. The poor man's way of doing it is do a triglyceride by HDL ratio. If you have double triglycerides than HDL, you're more likely to have small, dense LDL, the atherogenic profile. Ideally, you want your triglycerides to be less than the HDL. That would be the best situation where the ratio is less than 1. Triglycerides are less than HDL. You have a less atherogenic profile in that case. Hidden sugars, we need to, as doctors, we need to know how to read labels. Imagine that they will say there's no added sugar, but they will say evaporated cane juice. We should have some consciousness when we're reading labels like this, that if a processed food manufacturer is allowed to say evaporated cane juice, don't we know that means sugar, right? So there are too many ways that the manufacturing industry gets away with stuff, and it becomes the doctor's job to educate, but that's what we do. We're here for our patients, right? So we talked a lot about fats, we talked about carbs. Now let's look head to head, low carb versus low fat. Again, some studies. This was a RCT in lipids, carbohydrate restriction having more favorable impact on metabolic syndrome. So these are the at-risk subjects, and the type of diet given in the low carb was 45 grams of carb, 105 grams of protein, 98 grams of fat, and then there was the standard diet. And the atherogenic dyslipidemia at the beginning, and they did this improve, they showed this improvement in the marker of ApoB to A1 ratio. Again, it tells you about atherogenic particles and also particle distribution. So this showed a favorable effect by going with the extreme carbohydrate restriction. Actually, Dr. Volek and Steve Finney, they are pioneers in promoting this for diabetes reversal. This was another RCT in JAMA, low glycemic load versus low fat in, again, our young population, as Dr. Rao mentioned, that we have a very young population who's progressing into metabolic imbalance. So this applies in that sense, obese young adults. Low glycemic load versus low fat, 18 months, BMI 30 plus at the beginning. And the low glycemic load gave better weight loss, better loss in body fat percentage compared to the low fat diet, and better improvements in the HDL group, okay? So low carb improves cardiovascular risk factors better than low fat does. It's about time that we get out of the old conditioning of saying these things to people and change the way we give our advice. But everybody loves their carbs, right? So what to do? Should I have my carbs first? Should I have them last? What about fiber? What about the satisfaction I get from carbs? What is this whole grain topic? So briefly, concept slides. I don't expect you to read this. I'll just tell you the summary. If you're going to want to have your carbs, this is a study done by an endocrinologist who was in Mumbai. She's now moved back to New York, published in 2019. They looked at the exact same food, changing the order. So when you take your carbohydrates first and then your rest of the meal, you have more glycemic variability, more unstable sugars. Whereas if you start with proteins and vegetables first and then take your carbs last, your post-meal glucose levels are more stable. What about fiber? New England Journal of Medicine, May 2000 paper, 50 grams of fiber. The standard recommendations are 20 to 30 grams of fiber. This is a paper looking at 50 grams of fiber, 25 from soluble, 25 from insoluble. It's a simple Google search to look for images of what does 25 grams of soluble fiber look like. We need to know what this is because nobody ever went to the weighing scale and measured fiber. We don't do that on a day-to-day basis. So telling people 25 grams of fiber is not usable information. So just get yourself familiar with what are the portion sizes so that you can actually do this. And it showed benefit in 24-hour glucose and insulin profiles, plus improved triglyceride, just adding fiber. What are carbohydrate cravings? It's a pure effect on the brain, the psychological, feeling satisfied, the hedonic pathways, the dopamine pathways, the reward centers. That's why we all love and crave our carbs. There is a reason for it. So the more carbs you take, the more likely you are to crave them. Just knowing that, helping our patients with that awareness. And whole grain. Just because it was a whole grain in the field where it was grown, doesn't mean that when you have a whole grain or a multi-grain khakra or a multi-grain bread which melts in your mouth without chewing or without you cooking it yourself, that is no more a whole grain. It was a whole grain once upon a time. A whole grain needs to be cooked for 30 minutes and you need to chew it for it to get into your system. It cannot just go down as a melt in your mouth. That's not whole grain. So this is just to summarize what this slide says. So I stopped inpatient medicine because I just could not feel connected to that work. I believe my purpose is to help people stay out of hospital. And when we used to do the inpatient rounds, I would see the diabetic diet or the cardiac diet, and it would be loaded with carbohydrates. So the next time you're on rounds and you see what your patient is being served, which is a much higher ratio of highly processed carbohydrate, idli melts in your mouth and we praise it. The more it melts in my mouth, I say such a soft and fluffy idli. It has nothing to do with the whole grain rice, which was harvested long back. It has been gone through so many steps: parboiling, grinding, soaking, fermenting, and then steaming. It's highly processed rice and it is high glycemic. So this ratio needs to change. Bring the percentage down. If you really love your idlis and you want to enjoy it with the family, keep it, but reduce the portion. Increase your healthy unprocessed fats. Could be the coconut chutney, the ghee, the mulga podi powder, gunpowder. All these are saturated healthy fats, unprocessed. And your sambar needs to be full of dal, full of proteins, full of vegetables. Then it'll be a beautiful, tasty meal, and you would have immediately reduced your metabolic risk from this meal. What about salt? This is a big one. I spent a lot of time researching for this. So let's see if we can condense the information. Giving salt to normotensive subjects, about 80% of them do not see a change in blood pressure at all. Even in pre-hypertension, 75% don't respond. In people who have proper hypertension, 55% of them are totally immune to the effects of salt on blood pressure. And yet if we are blindly telling everybody reduce salt, reduce salt, reduce salt, guess what can happen? There are divergent BP responses to sodium restriction. 1980, these papers have not become popular because it was getting inconvenient. Everybody wanted to focus on saturated fat. Nobody wanted to focus on sugar or carbohydrates. So they focused on saturated fat and they focused on salt. Okay, and salt has gotten into so much trouble that now we have books written about salt, okay, to bring it back. So this was a study done on OPD and IPD patients where cutting salt out gave 28% of the IPD patients, their BP got worse, 17% outpatient. So it may not be the right advice for all your patients. Again, what happens with salt restriction? It's not the same thing to take a glass of water and put salt in and then say that the osmolality of this water has changed. The body is not so dumb. The body is not so stupid that if you put salt in your mouth, suddenly your blood pressure is going to go up. There are so many hormonal pathways to maintain normal body profiles. The body is always finding a state of homeostasis, so it has counter-regulatory hormones. Guess what happens when you start reducing salt? Aldosterone and sodium retention pathways will have to kick in because we need a certain amount of salt. What is the most abundant electrolyte in our blood? Happens to be sodium, right? So dietary restriction increases vascular resistance. This was a small study, 13 subjects, 8 of them had borderline BP, double-blind crossover. There was worsened insulin resistance in the low salt diet in the ones who had hypertension. Okay, we actually made insulin resistance worse in these people. These are expensive studies to do. These are like insulin clamps. You're measuring insulin responses hourly. It's very costly. It's very difficult to do these papers. 1989, New England Journal of Medicine. This was a fascinating paper. They took obese young teenagers and they were sodium sensitive. So when they were given sodium, their BP started to go up. So they had sodium sensitivity. They went through a 20-week weight loss program and then they became less sodium sensitive. Means after weight loss, when these same people were given salt, their BPs were not getting high. What does that tell us? That there is an intelligent hormonal mechanism that is adapting to your dietary salt. It is working to keep your blood pressure normal. So it backfires if you set up counter-regulatory aldosterone or hyperinsulinemia response. And cardiologists know all about hyperaldosteronism, right? So I don't need to say anything about why we don't want high aldosterone. So there is another thing which is just a sort of pop culture idea that there is a Korean paradox that they eat a lot of salt in these countries. So many countries have high sodium intake and yet lower cardiac rates. If salt was really that bad, we should have seen a clear signal in some way or form. In fact, even the Mediterranean heart healthy diet has many added ingredients that are soaked in brine. All these foods, capers, these fish, these olives, they're all sitting in salt water and they take it every day as a side dish. They have salty cheese, soups and fish caught from the sea, which obviously brings in some sodium. So we are celebrating the Mediterranean diet for its olive oil, but we should also look at the salt. This is a beautiful study, 2014, New England Journal. They measured urinary sodium and followed these people for mortality and cardiovascular events. It was a long-term follow-up, 1 lakh people in 17 countries, 3.7 years of follow-up. The cohort is called PURE, and they basically watched what happens to these people over time in life, long-term. And they saw that considering the urinary sodium ranges for the people who had cardiac events and death versus did not, there was a safe range between 3 to 6 grams of sodium daily intake, which is about 1 teaspoon, half a teaspoon to 1 teaspoon of added salt per day. And that was the safe zone. If you were taking less than 3 grams of salt per day, they were showing up with negative cardiac results. Higher than 6 grams of salt per day, negative cardiac outcomes. And this stayed as a sort of, it stayed significant even after correcting for so many other confounding variables. This stood out as an outlier, and it was so many countries, including India, were in this study. What about protein? Remission of pre-diabetes, giving them high protein diet. Now, high protein here is 112 grams of protein a day compared to high carb. Even in their carbohydrate group, they still got 56 grams of protein in this group. Okay, and what did they see with this? That when you were in the high protein group, you had better insulin sensitivity, cardiac risk factors went down, cytokines, oxidative stress went down, lean body mass went up compared to high carb. And guess what? We also know the other extreme is severe malnutrition directly correlates to increased risk of cardiac death in the long term. So you might be exposed to malnutrition in childhood or famine in childhood, and you have higher cardiac outcomes in later life. And I think, and we've done this, we measure our patients' protein intake every day in our clinic. It's something we assess on our clients every single day. And on day one, when they come in and we do their diet calculations, most of my patients who are predominantly veg, their daily protein intake is 10 to 30. So we are not even reaching the protein requirements which were in the high carb group in the study. Okay, so I think that India has gone from suffering from famine and energy or calorie malnutrition in some parts of the country. We have given back nutrition in the form of carbohydrates. Think about what we do when we have donations for the underprivileged. The majority of what we give them is rice and biscuits. We are giving them carbohydrates and we are not giving them enough protein. Even in well-to-do families, they are still sitting at 10 to 30 grams of protein a day, no matter whether they're affluent or not. So we have a severe problem of protein malnutrition in this country, which is a huge epidemic, which is driving a lot of our metabolic imbalance, driving our sarcopenia and muscle loss. Coming to muscle. What about exercise? This is, again, we all like proof. Even though common sense tells you exercise is good for you, we've become so used to sitting in chairs for 10 hours a day that we need proof that exercise will help. So, okay. Pediatric Journal 2014, looking at aerobic versus or cardio training versus resistance training versus both together. This was an RCT, and they checked body fat percent on MRI, 0 months and 6 months. There was greater body fat reduction in the cardio group compared to control, and greater body fat reduction in the strength training group compared to control. And the combination was believed to be more beneficial, although they weren't able to show that in the study, but there were some reasons why the authors felt that the combo would be better. Here's another paper in 2019, plus one, an excellent paper, RCT, checking aerobic exercise, which is cardio exercise, compared to strength training, which is weights and body weight, actually using dumbbells or your own body weight, resistance training, versus the combination. And these were high-risk people, adults with metabolic syndrome, hypertension, obesity, sedentary people, randomized to 8 weeks of 3 times a week. Either they got aerobic, one group got resistance, the third group got combination cardio plus strength training. And they found improvements in the combined group. The best outcome was with combo exercise in terms of blood pressure, cardiorespiratory fitness, obvious strength, and improved lean body mass. So across age groups, we need to get our patients to invest in combined. I think a lot of what we do is every time someone gets a diagnosis of a cardiac issue or diabetes, they're all willing to go for walks. We're very willing to go for walks. We're very willing to sign up for yoga. We need to make sure that we also get them to do their strength training. They have to do resistance training to get their muscle mass to increase. What is HIIT? We need to know about this because it's very popular nowadays. It is short bursts of vigorous activity that gets your heart rate up, and then you have rest or low intensity exercise in between. So it might be 20 seconds on, 10 seconds off, very intense, and then rest. And these workouts can be shorter. You'll see on YouTube, there'll be like 7 to 10 minute HIIT workouts. So this was a paper that showed that even HIIT, when used with overweight or obese patients, can help with our metabolic profile that we are looking at, whether it's insulin or blood pressure or body composition. And that was being compared to continuous workout, where it's a non-stop same intensity versus this sort of intense and then rest and intense and then rest. It also works. And we need to talk about sedentariness because we know that the diabetes prevention program trial, which was published in 2002, 20 years ago, it was proven to the world by the DPP study that lifestyle change is more powerful than metformin at preventing diabetes in people with pre-diabetes. This was proven, okay? And that was before the A1C of 6.5. Magically, we don't have studies after the A1C becomes 6.5 comparing lifestyle to drugs, and I won't have to explain why. But this study included 150 minutes of exercise per week, which you can say is 30 minutes of exercise 5 days a week. But if you're spending the remaining 23 and a half hours of the day, 23 and a half hours of the day, doing nothing but sitting in one place, which is called sedentary, you still have increased risk. So it's not only about 150 minutes of dedicated exercise, there's also something called daily activity. So there are studies now looking at that. Alternating bouts of sitting and standing. This was done. The target population you can see here on the right was overweight, obese, sedentary office workers, our high-risk population for cardiometabolic syndrome. What they were told to do is every 30 minutes, instead of sitting for the office work, raise the adjustable table and stand and do your office work. That's it. And every 30 minutes, they had to keep shifting the desk height and stand, work, and then sit and work, 30 minutes. And they found improvements in postprandial glycemia. Then there was a study looking at the breaks in sedentary time, where they made the patient wear an accelerometer on the trunk and measured sedentary time. And even if the amount of hours of sedentary time were same in both groups, the group that had X number of hours of sedentary behavior with breaks, where it wasn't 8 hours of nonstop sitting, but they were getting up and doing something, versus 8 hours of just sitting in one place, the breaks in being sedentary helped. So it makes sense to tell our people to get up and go walk around every 30 minutes. Just get up and move around and do something. And we think about our children sitting in schools, lecture. They need to be allowed to get up and move their bodies and not have them be locked down in desks in school. Okay, so we need to help do this combination exercise. And yes, I'm an endocrinologist speaking to a cardiology audience today, but guess what? There are so many cardiologists now talking about lifestyle change and literally giving solutions of how to make this difference in your clients and in your own life. And these people are doing a lot of work. These are just a few names that I read up and I follow their work, and I've learned a lot from them. And if you're very interested in the controversy, 50 years ago was when this big professional clash happened between these two people. It was a major sort of controversy, which is coming up to surface now. These are some of the books that I've read over the last 15 years and continue to do so. All interesting books about calories, about just food in general, weight gain, low carb performance for exercise. Again, this is by an endocrinologist. This book is by a cardiologist. This lady is an investigative journalist, and she's exposed the sort of saturated fat problem to us, that it was wrong. This is again conventional, challenging conventional nutrition, the book on salt, the book on healthy fats, a book by an endocrinologist on why are we always hungry. This whole book is about insulin. Longevity, of course, if we're trying to prevent cardiac events, we're very much interested in longevity. It's the same, two sides of the same coin. And Obesity Code by Jason Fung, fantastic book. I learned more about insulin physiology from this book than I learned in my fellowship. And that's just because that's the way we're taught. We're taught to focus on disease and not physiology. This is a beautiful book released last year, Why We Get Sick. Another book, I didn't get time today to cover fasting and intermittent fasting, but there's a whole idea of time-restricted eating. This is a brand new book that has come purely on uric acid, and due to interest of time, I had to remove some slides, but the idea of uric acid tying into cardiac risk, and it comes purely from sugar and insulin resistance and not from purine-rich vegetables and pulses and lentils. So please don't get your audience to stop. There is no evidence that eating purine-rich vegetables causes uric acid events. So please let them have their healthy vegetables, pulses, and beans. And this is how you can reach me, and I'm going to now stop. Thank you.
Excellent talk, Roshni.
Thank you.
Wonderful as expected. And you covered virtually everything. So if we look at today's flow of event from lifestyle parameters, that we see 8 components, and 9th one is the component of the women. So those, and then this study how ACS can, metabolic change in the body can impact the ACS, the coronary event. And then this diet and exercise can reverse it. So what we have is a mechanism which we all need to understand. What is that mechanism which can reverse everything? A good healthy diet and physical exercise. It's very simple prescription, but we are not able to follow it Even doctors are not following it. So we need to follow ourselves first, and by example we give to others. So I keep on saying that if you don't follow today, then waiting list in our hospitals will keep on increasing. If you see the waiting list in England, it's huge waiting list. Patients are waiting for coronary angioplasty and bypass surgery. So where we can go like this? So what we are eating is a junk food, processed food. We need to go back to our earthy food, which is directly from the Mother Earth. That is fresh vegetable, fresh fruits, and directly eat raw beans boiled. That's the best healthy diet. You don't have to worry for anything. And this is what I follow in my life. I don't eat chapatis at all, no rice. I was just talking to Roshni yesterday. I eat only fresh chopped vegetables, fruits, add pulses, and some fresh curd from the cow curd. So that together I add little salt, and that is my whole meal. It keeps you very healthy. You don't need to eat anything else. 3 times if you eat this, and you can eat some nuts at times when you want to munch something hard you need to munch. So you can eat some great nuts, which are available to everyone. So this is a good diet, and we are processing it too much. We are not eating good food. Simple good food is directly from the Mother Earth. When we are born, we get mother's milk, and after we are grown up, direct Mother Earth will give you food. But we are unable to understand all this. The science is taking us elsewhere, and the money game, this economy spinning, that is causing the processed food. So many processed food joints have opened. They have become world-renowned. They have become filthy rich. What they are giving is diseases, and we are filling the hospitals. So I think this is a process which we need to change. Certainly we can make impact. Like tobacco, we make an impact. If we add physical exercise and healthy diet to our prescription every day to every patient who comes to us and speak in all our conferences, it will make a difference. It will bring down the coronary artery disease without practicing this back-down medicine. That is my message today. But I appreciate the study that you have done, Dr. Hygriv. It's a very wonderful study. It is a very focused study. I was thinking I have a DNB student, fresh DNB student coming to me. I was thinking, why not give him this topic as a thesis in my hospital? So it's worth it. And we all have to move in that direction. Good food, good, normal, healthy food, directly from the Mother Earth, fresh, and a good exercise. That's all. Means what I do in the hospital, I'll tell you that simply. I don't sit in one place in the hospital because we don't need to sit. I keep on moving from one floor to other floor. I don't feel like chatting with anybody and sitting in the group. We have doctor's lounge and all that. I don't do that. I keep on moving from one place to other and meet people and enjoy myself if I have free time in the hospital. And of course, we have to all work very hard. No doubt about that. We are standing in the cath lab for hours for doing the procedures. So all that lifestyle is also there, but then we have to learn this. And one more thing that we can add, if you want to reduce coronary event, a healthy mind. And healthy mind comes from good meditation and breathing exercises. It definitely helps. And divine meditation. I do that every day. Get up at Brahma Muhurat, do divine meditation. It's very helpful. It gives you strength, increases your soul power of your soul. That is what you are. You're genuinely a divine power. So we need to change ourselves, guide our people rather than practicing this back-down medicine. And I fully agree with Roshni what she has done, left the hospital practice, adjusting two units of insulin and putting a visit. rather than that, guide people for a better lifestyle. She's going to publish a book on that. I'm happy that she's doing that. And even I am going to promote that book. Why not? So all in all, I think we had a very great session. And now we can take some expert opinion. We have great doctors, Dr. Manish Bansal, Dr. C.S. Srinivas Raju from Nellore, and Dr. Hygriv Rao, and also Roshni. So we have expert. Let me take brief comments from each one of you. Manish?
Yeah. Good evening, sir. So, these two presentations, first one by Dr. Hygriv Rao, describing the findings of the study that he conducted, his group, and then by Dr. Sanghani, bring to the focus the very problem that we are facing, our country is facing today. That in the hospitals, clinicians are busy with doing the core cardiology work, and in that process, they are not focusing on the areas where the attention is really needed. That's one problem. Second is many cardiologists are also not aware of the right thing. Every day, when I see patients, I struggle to break the patient's obsession with fats. Whenever we talk about diet, the first question the family will ask, "Sir, ghee ka kya karna hai, oil ka kya karna hai?" I tell them that reduce sugar, potatoes, white rice, and then they'll say, "Sir, he doesn't have diabetes." They'll say about the patient. I tell them that it's not about diabetes. It's not about the patient alone. It's about the whole family, everyone. So, but I don't think many clinicians have that much time to spend with their patients and clarify this. And this study, which Dr. Hygriv Rao has conducted, shows again that these factors are very important. Focusing only on smoking, diabetes, and LDL is not enough. And then Dr. Sanghani very beautifully described the whole science behind the correct diet, proper diet, and physical activity in reducing cardiovascular risk. So I think overall very informative session.
Yeah, Dr. Raju.
Yeah, good evening, everybody. As both the speakers have done an excellent job of bringing out the metabolic risk factors. Dr. Hygriv and myself, we are all part of that study. And then it was very difficult to do the job, collecting all the samples from all the patients and focusing on the things which are rather less understood, less utilized. So everybody knows about the diabetes, hypertension as the coronary risk factors. And then when we focused on these particular things, they are very cost effective, very user friendly. It can be done at any center without using much of finances involved in that. And then they're give valid information about the first instance of acute coronary syndrome like STEMI or NSTEMI. So that is being very well emphasized by my friend Dr. Hygriv. And about the second part of the study, the diet, as we all know that the diet plays a very important role, and exercise and the sedentary life, all these things are very important. And as clinicians, we always spend time with every patient, probably the equal amount of time by prescribing the medicines. And not only that, the lifestyle changes are equally important or even more important than giving drugs alone. And we have to emphasize every patient, and then we have to look into their dietary patterns, what exactly they are taking, and then how they can be modified, and what are the myths in their minds, and that can be rectified. And then these things are very important in anybody's clinical practice. That becomes what you call as a comprehensive management of a patient and their profile, the diet profile as well as the drug profile. Thank you very much for giving me this opportunity.
Excellent. Excellent viewpoint by both the expert, Dr. Manish Bansal and Dr. Raju. Now we have Nishita. Are you there up there? Nishita?
Yes, sir. I'm here.
So
only.
where are the question answers?
Sir, I have pasted the questions in the chat section.
Chat section.
Yes, sir.
Okay. Only 2 questions?
No, sir. We already received 10 questions. I am pasting one by one.
Okay, so let me go through each one of them. Is there a relationship between tuberculosis and myocardial infarction or COVID-related mortality? Any of expert would like to answer? Hygriv?
I think Manish is the best person to answer that question.
Okay.
See, regarding COVID, when the pandemic initially broke out, there was a lot of apprehension that it was going to cause a tsunami of cardiac problems. But later we realized that yes, it does increase the risk of cardiac problems, but maybe the risk is not that high as was anticipated. However, because of the sheer volume of people who have suffered from COVID, mild, moderate, or severe variety, we are seeing a good number of patients who are coming back with various cardiac problems. So this is something which cannot be ignored, but I don't think COVID alone can be considered to be a big risk factor to cardiovascular mortality as was initially thought to be.
And tuberculosis? She is also asked tuberculosis.
Yeah, tuberculosis
and myocardial infarction.
Myocardial infarction and tuberculosis, I'm not aware of any direct relationship.
Okay. Now this is one question. Second one is, which marker is for apoptosis and necrosis? Apoptosis and necrosis.
High sensitive troponin, which is the most reliable marker for myocardial necrosis in day-to-day clinical practice.
Correct.
Apoptosis, I don't think we have got a good reliable biomarker for measuring apoptotic process.
I think only one way we can see, I don't know, I'm coming to your area. Echo,
yeah.
Strand rate imaging?
It will pick up
Can it show some fibrotic element?
Yeah, fibrosis, myocardial necrosis.
That indirectly suggests that there can be apoptosis, possibly. Yeah. Especially in patient with heart failure.
Yeah.
All right. Then isoproterenol and isoprenaline protocol for myocardial infarction. Hygriv, this is your question. You're a STEMI man now.
No, I'm not sure we use isoprenaline for detection of or diagnosis of myocardial infarction. I'm really not aware why you use isoprenaline to detect myocardial infarction, sir.
I'm just wondering, are the participants posting questions in the correct chat box, or they're listening?
Yeah, there are several questions, but many of them are not relevant to our present topic today. Yeah. That is true. Questions should have been relevant to present topic today.
Yeah.
But there are, since we have, the delegates are asking this question, it becomes mandatory for us to at least talk something about it.
Yes.
Because otherwise we don't want them to get dissatisfied with us, that these guys are no good for asking any questions to them.
Oh, definitely, sir.
So we are trying to go through the question list. So another, how to detect myofibroblast in myocardial infarcted hearts. I only know one thing, that if you have a myocardial infarction, stem cell therapy can be tried. And stem cell therapy, not fibroblast, myocardial cells are removed and re-injected from the patient's cell. Blood is processed, they remove the myocardial cells and inject it into coronary. So that stem cell therapy kind of thing. Sorry, say that.
Myofibroblast. See, I think more clinically relevant is the question should be on fibrosis in myocardial infarction.
Absolutely.
Yeah.
So that is what it meant. I don't know. I mean, I feel like there are some questions which are not very clear. What the delegate wants to ask. Then are statins able to reduce?
At least let us make it clear that.
Are statins?
Sir, I just want to.
Yeah, please.
Sir, I just want to make one point that this myofibroblast and myocardial, see, at least fibrosis, we need to just tell them that the way to detect fibrosis these days is a cardiac MRI, which is as good as a pathology detection of fibrosis. So it delineates the fibrosis very well these days by gadolinium, late gadolinium enhancement as it is.
Absolutely, absolutely, no doubt about that. Then there is another question, that is, are statins able to reduce myocardial infarct size and improve myocardial remodeling?
Yes, definitely, sir. They reduce.
Raju, you like this question, I know.
Yeah. The statins have been shown to reduce the remodeling as well as the limit the infarct size, not only by direct ways, but also by various pleiotropic effects.
Yeah, statins are known to be pleiotropic mainly by reducing the CRP.
Yeah.
Okay, that's true. So then the Dr. Alka Srivastava, if isosorbide dinitrate and aspirin are available in a non-hospital setting of an acute myocardial infarction, can they be given at once? Soluble aspirin, certainly if you have a delay in reaching a thrombolysis center, thrombolysis capable center, or primary PCI center, you can certainly give soluble aspirin in glass of water to the patient, because the main process that happens in acute myocardial infarction is thrombosis, platelet aggregation. So if you give antiplatelet agent, which will act fast, is a soluble aspirin in a glass of water. It can definitely produce antiplatelet effect in short time. Then
just one point here.
Yeah, please.
Yeah. So in case of any acute coronary event, suspected acute coronary event, we should focus on giving aspirin, as I mentioned, plus statin, rather than thinking of isosorbide dinitrate, which causes more problems than any benefit.
Yeah.
No mortality reduction. Statins should be given immediately.
Okay.
Yeah, we keep on advising about the use of sorbitrate. A lot of people have a habit of giving sorbitrate. Suppose if it happens to be an inferior wall MI with right ventricular infarction, if you give the sorbitrate, that fellow will never reach the hospital. I always keep telling in the awareness programs, please, if somebody is not having a knowledge about the type of infarction or the presence of hypotension or not, never give isosorbide dinitrate or sorbitrate for that matter. Sometimes you'll be causing more damage than the benefit for the patient.
Then Dr. Ramakrishnan, in myocardial infarction with ST segment elevation, is it to rely on ECG data? Or if so, what extent we can rely on ECG data? So I think this is quite good parameter to pick up the myocardial infarction, the surface ECG, which is available everywhere and quite reliable, except in some patients it might cause some delay in ECG changes to appear. And there it may remain a little bit challenge for interpretation as myocardial infarction in a given setting. But you have to look at the clinical. If clinically very convincing angina is there, and you think it is classical angina lasting for more than 15-20 minutes, then likely to be myocardial infarction. ECG changes may come later. Do echo and do cardiac enzymes and look at them. You can take supportive measures to decide about whether this is a myocardial infarction or not. Then myocardial infarction, does the myocardial infarction affect gastric acid secretion? Roshni, you are the best.
I think maybe it's not causal, but the correlation or the common factors between both would be the inflammatory state, whether it is the cortisol that's going high, that itself will trigger gastric irritation, inflammation, and cortisol may be playing a role at the time of the cardiac event. So I think there are common factors which could be playing together. I don't know that we have a way to say it's causative. But
absolutely.
Inflammation is the common piece.
Then there is another question by Dr. Ananya Pandit. How can we detect cell apoptosis on cardiac tissue slides? I think shall we pass, because we'll need a pathologist to say so.
Pathology question.
Okay. So
Pathologist.
please ask
Number
pathologist
6,
this question.
Sujan
Dr.
Patra,
Ananya
sir.
Pandit, please ask this question. Then Sujan Patra, aspirin versus P2Y12 plus NOAC after myocardial infarction in patient with AF. So Manish, I think is the right person to answer.
In patients with ACS, MI or non-ST elevation ACS, with or without PCI, if they also have AF, it is generally recommended that we give triple therapy for first week. In some patients in whom the bleeding risk is not that high, we may continue triple therapy for 1 month, but after that it's mostly dual therapy, which includes a NOAC plus P2Y12 inhibitor, preferably clopidogrel. And the duration of this will vary from 6 months to 1 year, depending on the bleeding and ischemic risk. After that, the guidelines recommend that we should use only NOAC, no antiplatelet needed in a patient who has AF and requires NOAC.
I think we are done with the questions. So question answer session is over. Is Nishita there?
Yes, sir, I'm here.
Yeah,
you.
so let me put a brief closing comment, and
Sure,
then
sir.
you give vote of thanks.
Thank you, sir. Sure, definitely.
Okay, so if we go, I mean, what we have a session today is because of that study, which was done by a very focused study done by Dr. Hygriv Roy, which was a very intelligently done study, and particularly metabolic parameters. It is very relevant study in today's day because increasing BMI, lack of exercise, and poor diet. I showed you on the slide, poor diet, even in highly educated country like America, highly, economically higher class country in America, they also can't understand what is the value of diet and exercise. It's very poor. That means somewhere we are lacking in, as a medical community, as the healthcare worker, somewhere we are lacking in convincing the community what is good health, how good health comes from good diet and good exercise. That is the only formula which is there for good health. So now coming to, that's all. I think this is the end of the session. I think everyone has contributed a great deal in making this session very successful, in my view. And let us close the session with vote of thanks by Nishita.
Thank you so much, sir. Let me share the vote of thanks. It has been such an honor to be part of this wonderful event. The event was so interactive that in the process, I have also learned a lot. I'm very much sure that all the attending doctors must have also enjoyed the whole session throughout. So on behalf of ClearNet, I would like to extend my heartfelt gratitude to Professor Dr. Vijay Bang sir, Dr. B. Hygriv Rao sir, and Dr. Roshni ma'am, and all our esteemed panelists, Dr. Manish Bansal sir and Dr. C.H. Srinivasa Raju sir, for giving your precious time. Thank you so much, and sincere thanks to all the heads of the various departments who handled the events throughout. A wide round of applause and thanks to all the participants who made this event a memorable one. And finally, I would like to thank all of you present here for making the time to be with us and today and helping us to make this event a great success. Thank you one and all. Thank you so much, everyone. And I wish everyone a very good night.
Bye.
Thank you.
Thank you.
So, all of your permission, shall I conclude the session here?
Yeah.
Please
Thank
do.
you so much, everyone.
Thank you.